So it's a privilege and honor to be here with all of you today. And I'd like to thank MPNAA and Anne Brazeau and MPN Advocacy for putting this wonderful event together. And I'd like to thank our Australian colleagues, but most importantly, all of you for being here, for investing in your own health knowledge, because I think that's fundamental to dealing with having this diagnosis. So we're going to talk a little bit about interferon and what we know, what it can do, and what are the current controversies and thoughts about the future of interferon therapy. We've seen a lot of bone marrow slides, so I've included a photograph of New York and your beautiful city. As you can see, I have no future as a photographer. So there's going to be a fair bit of repetition in terms of the biology, but I think that's important because that does drive home the point a little bit. So the MPNs, as we've talked about, are really a family of diseases. And within that family, there are a number of things that we've talked about that we're going to focus on today, principally PV and ET, as well as myelofibrosis. But there are other more rare things, such as chronic eosinophilic leukemia and things like mastocytosis, which, again, are quite rare. So the genetics are important, and we won't spend too much time, but I think I want to just focus for a minute or two because we're going to talk about genetic implications. This is a picture of the cell surface. So if you imagine this is the outer ridge of the cell, what the JAKs do is they're there to take signals from the outside of the cell and bring them and transduce them into the nucleus of the cell, the brain of the cell, to turn on certain gene programming. And when someone has a mutation in JAK2, as was pointed out earlier, it's like turning on the switch. It turns on the programming in the cell. Now, the family of mutations that cause the disease are JAK2, which is about 95% of patients with PV and half of patients with ET and MF, but also calreticulin, which has been recently described, and we think that works in this same mechanism pathway that I've demonstrated here. And then there is MPL, MPL, and MPL is actually, if you schematically look at this blue part, the MPL is sort of the antenna outside of the cell that takes the signal in, and it connects to JAK2. So it makes sense that if you corrupt one part or the other, you get sort of the same type of disease. There are very rare mutations in something called LINC, which under 5% of people have. So the three major ones, again, are JAK, MPL, and calreticulin. So before we get into the effects of interferon and how we use it, the first question is, why do we treat somebody? What is the purpose of treating somebody with this disease? So if we think about the diseases, and we'll focus again on PV and ET, patients with PV can have many different symptoms, and this can include itching and fatigue and shortness of breath and dizziness, and symptoms related to having an enlarged spleen. People can have cardiovascular complications in the sense of having a thrombotic event like a heart attack or a stroke, as well as blood clotting elsewhere in the body. But if we think about the things that we all worry about with patients with PV, certainly we worry about progression, but the 15-year risk of progression to myelofibrosis or leukemia isn't that high. It isn't the major thing we worry about, but we certainly worry about it. The major risk is blood clots, and at 15 years, about 27% of patients will develop a blood clot. So the symptoms are a big driver of this, but also the risk of having a blood clot. ET is similar in the sense that patients can have a lot of different symptoms, and that can include things that are related to what we call microvascular complications. So people can have new onset migraines, dizziness, numbness, burning and tingling in their hands, blurred vision. Occasionally, and less frequently than in PV, people have night sweats and weight loss. But again, overwhelmingly, if you look at the risks at the bottom, leukemia and myelofibrosis, evolution to those diseases, are certainly there. But again, it comes back to thrombosis being the major problem that we encounter as a consequence of having these diseases. So with that idea in mind, what are the goals of therapy? The goals of therapy are to reduce symptom burden for patients, to improve patients' quality of life, number one. And number two, to decrease the risk of thrombotic events. And that is sort of how we generally approach the treatment of these diseases. How do we do that? Well, there's a couple of different ways that we can do this, and of course many of you are quite familiar with these things. One is phlebotomy, which we do in patients with Polycythemia Vera. We bleed them. The other is to use antithrombotic modalities, so things that affect how platelets function, like aspirin. Aspirin will reduce clotting. Lifestyle modification, which is extremely important. Things like keeping your cholesterol under control, keeping your blood pressure under control, keeping your weight under control, not taking up smoking. All of those things are very important. And then finally, we come at the very bottom of all of this to chemotherapies, or what we term cytoreductive agents, meaning agents that lower the blood counts. And these include things like hydroxycarbamide, also known as hydroxyurea, interferon, enegrelide, ruxolitinib, and older drugs like busulfan, which are not so commonly used. How do we decide who needs treatment and who doesn't in terms of medication? Well, we stratify patients into low risk and high risk, and this is very general, but anybody who's under the age of 60 and has never had a thrombotic event and has platelets under 1.5 million is somebody we deem to be at low risk. Low risk is not no risk. It's important to remember that, but generally speaking, it would make us think that the risk of giving therapy is not justified in a patient who is quote-unquote low risk. People who are high risk are anybody over the age of 60 or anybody who's had a previous thrombotic event. And based on this schema, we decide who needs treatment to lower the blood counts and who doesn't. For ET, there's also another scoring system that takes into account patients' white blood cell count, as well as the age and history of thrombosis. There is an association with an increased risk of a clot when patients have a higher white count. So what do we know about interferon historically? Interferon has been used for probably about 30 years at this point for the treatment of MPNs. And it certainly has shown a great deal of efficacy. So if we look at some trial data, and this is in patients with PV, this is a phase 2 trial of Pegasus, which is a once-a-week formulation of interferon in patients with PV. What was observed in this study was that there was a complete response rate of 94%. Complete response was measured by whether or not the blood counts were controlled. There was some toxicity observed, and 50 out of 40 patients had to discontinue treatment. But if you look at the shape of this curve, what's important to note is it takes time for interferon to have its effect. So if nothing is happening by a month or two, that doesn't mean it's not going to work. It's important to realize that there is an increase in response over time. If you look at phlebotomy, again, it's one of the modalities we use to treat people with PV. If you just look at that top line here, if you look at the number of phlebotomized patients, at the beginning of the study, it was 25 out of 37. By the time you got to month 24, it was 1 patient out of 28. So again, that is giving you another piece of evidence that interferon is able to control the counts in patients with PV. And then we come to this idea that maybe interferon can reduce the amount of the bad gene of the mutant JAK2 in the blood. So there's a concept called allele burden. I'll spend a minute here to explain it because we're going to come back to it. What allele burden simply means is that everybody has JAK2 in their blood. So there is a percentage of mutated JAK2 that somebody can have. So the ratio of the mutated JAK2 to the normal JAK2 is what we term the allele burden. What we know is that in patients with ET, there tends to be a lower allele burden, but in patients with PV or MF, there tends to be a higher allele burden. So it's the percentage of bad gene over good, as a very simplistic way to think about it. So what was interestingly observed is that if you look at the allele burden in PV patients who are treated with interferon, it drops over time. And that would seem to indicate that you are clearing out the cells that are causing the disease in principle. And over time, it certainly decreases, just as we saw an increase in the response rate over time. The same thing, that's not exclusive to JAK2. It's also true of other mutations like calreticulin. So if you look at patient 1 here, the allele burden is in gray. So this patient started out with an allele burden of 42% mutant calreticulin. They were given interferon, and over time, since diagnosis, it dropped to 6 to 10%. So again, you are able to decrease that burden. What about ET and interferon? Well, there's been a number of different studies that have looked at responses in ET patients. And again, if you look at the response rate here, you can see that it ranges from somewhere in the 70s to 100% in some studies. That's actually a pretty profound response rate. One of the issues that we do run into sometimes, though, is toxicity. And if you look at this discontinuation rate, it can be as high as 55%, but in some cases, in some studies, it was 0%. So we have to be mindful of the toxicities of these therapies, and we'll come back to that in a moment or two. This was a phase 2 study of PEG interferon. Again, this is the once weekly dosing of interferon in patients with ET. And as you can see here, 76% of patients in this study had a complete response, and another 5% had a partial response. It was really only the minority of patients who didn't have a response. So again, it's showing itself to be an effective therapy. And as we saw with PV, there is a reduction in this allele burden over time. Now, of course, the story can't be that simple. We had talked earlier about the number of mutations and the contrast to CML. And in CML, there is one genetic driver. In MPN, non-CML MPN, it's not so simple. If you look at patients with ET and PV, this is a representation of the number of mutations an individual patient might have. And in 55% of patients with PV, there is one mutation. But in probably about a quarter or more of patients, there is 2 or more mutations. So what does that mean? If you reduce the allele burden of JAK2, but you have another mutation, does that mean that it won't work as well? Well, the answer is we don't really know the answer. This is a study that looked at patients who had more than one mutation, and they looked at this allele burden for the JAK or MPL or calreticulin mutation, as well as the other mutation that the patient had. And there's no clear pattern. So if you look at the top here, this patient had what we call an IDH mutation and a calreticulin mutation. The calreticulin mutation went down steadily over time, but the IDH mutation was not touched. In another patient, both mutations went down. And in a third patient who had 3 mutations, 2 of the mutation levels rose while the other one fell. Some of the data has suggested that the more mutations one has, the less likely there is to be a response to interferon. And that is something we're working on in the lab right now to figure out in larger numbers of patients. But we need more data here before we make any conclusions. So other modalities of treatment include hydroxyurea. And that has been used in PV. It reduces the incidence of thrombosis. There has been debate about whether or not hydroxyurea contributes to leukemia, but to date there's been no large-scale evidence to support that idea. Hydroxyurea has been also used effectively in patients with ET, and this is just demonstrating that you have a decline in platelet counts in patients treated with hydroxyurea compared to a different drug. But the point more is just that hydroxyurea is effective at controlling blood counts. What about ruxolitinib? So ruxolitinib has been studied in patients with PV, and it was studied in patients specifically who had been on hydroxyurea but had failed hydroxyurea therapy. Either the drug caused toxicity or it just wasn't working. And in those patients, what was found is that ruxolitinib was actually highly effective. So if you look at these 2 bars here, one is hematocrit control. So hematocrit, again, is the concentration of the red blood cells. Over time, ruxolitinib was much better at controlling that hematocrit versus standard therapies. With regards to spleen size, again, ruxolitinib was more effective at reducing the size of the spleen in PV patients than were standard therapies. So we know that it is an effective drug in PV. As well, ruxolitinib was better than a lot of other medications in reducing symptoms related to PV, things like itching, night sweats, fevers, muscle aches. All of those things improved on ruxolitinib. So at the end of the day, this is the question and the conundrum right now in 2017. what is the best approach to treatment if somebody needs treatment? What's the right first-line therapy? Should we put everyone on interferon? Should they be on hydroxyurea? Should they be on a clinical trial? Which is never the wrong answer, since we don't think any of these therapies are curative by themselves. What should be the second-line therapy? If somebody fails interferon, should they go on Hydrea? What is the right sequence of therapy? This is an open question, but there are studies addressing that, and that's what we're going to talk about next. There's been one study to date that has given us one definitive answer, which is that in somebody who has PV, who starts off taking hydroxyurea, if they have resistance or intolerance, they can be switched to Ruxolitinib. There's good data for that, and that's what we just talked about. So we've figured out one pathway, but we need to figure out the rest of these pathways. So one of the studies that has sought to address this was the MPD-RC 112 study. This is an international study led by the Myeloproliferative Diseases Research Consortium. And the study sought to take patients who had previously been untreated and randomize them to hydroxyurea or interferon in first line. This is data that was presented at the American Society of Hematology meeting in December last year. This is a report on the first 75 patients. What the study showed is that if you look here, we are looking at two cohorts. HU is hydroxyurea, PEG is PEG interferon. PR is partial response, CR is complete response, and ORR is overall response rate, and that is the combination of the CR and the PR. So how did patients do? If you look at the number of patients who had a complete response, it was 33% with hydroxyurea and 28% with interferon, which was not statistically different. Remember, this is an analysis after 12 months of therapy. In patients, in terms of the overall response rate, it was 81% with interferon versus 69% with Hydrea, but that is not a statistically significant difference. And PRs were roughly the same, again, not statistically different. What were the toxicities, though, that were observed in patients treated? Well, depression, which was much more significant with interferon, and we've known that to be a side effect of interferon for some time. Shortness of breath was more frequent with interferon. Injection site reactions, obviously, if you're taking a pill, you should not have an injection site reaction. And itching was a little bit more common in patients who got interferon, statistically. In terms of count control, hematocrit control in patients with PV, it was roughly the same, 76% with interferon, 57% with hydroxyurea, but not statistically different. In terms of platelet count control in patients with ET, again, exactly the same, 73% in both arms. And if you look at the response in terms of spleen, this is what we call a waterfall plot, and each of the bars represents a single patient. And if the line goes below 0, that means there was a reduction. If it is above 0, that means there was an increase. All of the patients treated with interferon had a decrease in the size of their spleen. These are only patients who started out with a big spleen, whereas most of the patients with a big spleen treated with hydroxyurea had a decrease in their spleen size, except for one patient. So in terms of looking at the bone marrow to see if there's been a response, largely the numbers were relatively the same, 8 out of 22 versus 2 out of 24. Again, these are small numbers and we need more data. If we look at the allele burden of JAK2 reduction, with both hydroxyurea and interferon, there was a reduction in the mutant JAK2 from roughly 18 to 19% to about 8%. So that's one study, and again, that's only 12 months of follow-up. There's going to be follow-up data after another year of therapy for those patients. Now, another study that looked at a similar question was something called the PROUD-PV study, and this was conducted in Europe. And the idea was very similar here, where patients were randomized to hydroxyurea or something called ROPEG interferon. This is a newer form of interferon that's actually given once every 2 weeks instead of once weekly. So the idea was to look at what happened after 12 months of therapy and then to follow patients for 3 to 5 years afterwards. The idea being, if you remember back, we looked at that curve of response. It takes time for responses to occur. So after 12 months, we still might see people having responses to interferon. So we have to keep that in mind. In the initial study with this schema at 12 months, it looked like the responses were roughly the same with the interferon, which is called AOP2014, and hydroxyurea. So both arms, as with the previous trial, showing that maybe the responses are the same in patients. If you look at the hematocrit for patients, in the clear circle is patients treated with hydroxyurea, and in the solid circle is the patients treated with the interferon. If you look at that over time, the lines roughly merge together. So indicating at over 12 months' time, you're seeing the same response. And in terms of the mutation allele burden, that's in purple here, the lines are indistinguishable. They overlap completely. There was no appreciable differences in spleen change because most patients didn't have an enlarged spleen in the study. So after 12 months, the conclusions seemed to be somewhat similar, that maybe there is no difference. But the authors then presented data for follow-up after that 12-month point. And this is what they found, which is really interesting, which is that if you look at the response rate, so we have the percent of responders here. In red is the interferon-treated patients, and in gray are the hydroxyurea-treated patients. Over time, there starts to be some difference, right? If you look at the very end of the curve, once you're getting past 18 months, the curves start to split in favor of interferon. So what can we conclude? We can't conclude anything. We need more data and we need more time. But this is ongoing, and there will be more mature data, so we will have a more definitive answer. But for the time being, all we can really say is that roughly speaking at 12 months, it looks like interferon and hydroxyurea behave similarly in terms of how people respond. We'll skip through some of these adverse events. What about interferon in myelofibrosis? Well, interferon has been studied in myelofibrosis to a lesser extent than PV and ET, but it certainly has been studied. So this was a paper where patients with what we call low risk or intermediate 1 risk myelofibrosis were treated with interferon. And these are patients who don't have as much in the way of symptoms or enlarged spleen. And what was interestingly observed was that there were complete remissions observed in this study that was from one single center, as well as a number of partial remissions to therapy. If you look at spleen size before and after therapy in these two columns, you can see that there was a reduction in spleen size in many of the patients on the study, and that there was a reduction in the JAK2 percentage in many of the patients. In another study of 63 patients that was performed in Europe, a very similar thing was seen. And again, these are patients with earlier myelofibrosis. These are not patients with advanced myelofibrosis. In terms of reduction in spleen, about 50% of patients had a reduction in their spleen size, marked reductions in symptoms, reductions in their blood counts, and I think importantly, a reduction in transfusion requirements in a proportion of patients. These are, again, not very big numbers. What was observed, though, is that patients who have a spleen size greater than 6 centimeters didn't really have a good response to therapy. What that might indicate is that interferon could be effective for patients early on with myelofibrosis, but perhaps not so useful in patients with more advanced forms of the disease. So if interferon works and ruxolitinib works, why not put them together? Not a bad idea. And this was data that was presented in 2015 at the American Society of Hematology. And what the authors did was they took patients with PV, ET or post-PV or ET-MF, and gave them ruxolitinib plus interferon, the regular interferon. And if we look at responses, out of 30 patients enrolled, 19 of those patients had a response. Breaking it down by disease, 15 of 20 patients with PV had a response, 2 out of 7 with myelofibrosis, and 2 out of 3 with post-PV MF. So there is certainly activity. The problem is that this is not a randomized trial. You're only comparing one arm. So what would happen if you just treated those people with interferon or just treated them with ruxolitinib? We don't know, but that would be a trial to do in the future. There wasn't a decrease in this allele burden again, and there was a marked decrease in patients' symptom scores. But the more important thing to take away from this is that there was no overt toxicity, and that would be the one concern, is if you're combining agents, you might see a lot of toxicity. But certainly that wasn't the case. There wasn't a danger signal, and this is an idea that's being explored further. Okay, so a couple minutes left, so I'm going to just quickly, very briefly, touch on what are some of the new ideas. So JAK-STAT signaling is fundamental to all MPNs. Regardless of the other types of mutations, this pathway is fundamental. So how do we do better for patients? We either need to build better JAK inhibitors, or we need to find other ways to target these diseases. And there are a lot of different ideas as how to approach that. There are novel JAK inhibitors that are in development, and certainly that is one worthwhile way of approaching the problem. But there is what we call epigenetic targets. And what epigenetics just means is that this is, if you think about DNA, DNA is not a strand in the cell. It's wrapped up very tightly, and cells need certain signals to unwrap the DNA in order to utilize it. And that's a lot of what epigenetic modifiers do. What we have begun to learn is that epigenetic modifiers are involved in all types of cancers. They tell the cell to turn on genes inappropriately, and that contributes to cancer. And so there's no reason to memorize this slide. There will be no quiz at the end of this. The point is that these are a bunch of modifiers that are involved in cancer. And importantly, a lot of these are now targetable. We have had drugs for a while that target, for example, these things called DNMTs. We have a new class of drugs called bromodomain inhibitors. We have a class of drugs called lysine demethylase inhibitors. This is not here to intimidate you. This is here to, I would say, inspire you. We have a lot of new drugs that are being tested in combination with the drugs that we know already work. And these are things that we're exploring both in the laboratory but also now in clinical trials. So I think that should be the final takeaway. So with that, here's what I would say you should take away from the interferon story. We have to give some people, drugs to reduce their blood counts, and we've talked about what those criteria are. Interferon is effective for the treatment of ET and PV patients. Hydroxyurea is effective for the treatment of ET and PV patients. Ruxolitinib is effective for the treatment of PV patients, maybe ET patients. There's some data there. Is one of these better than the other? It depends on what you mean by better. Is better controlling the counts better? Is better controlling symptoms better? Is better putting the disease into a full remission? We have to define that, and we need more data. But that data is forthcoming. As we've talked about, those two major trials that we've discussed today, there is more data that is being accumulated over time, so we will have answers to these questions. What's the right sequence of treatments? Again, this is something that we're working on, and this is a focus of investigation currently. We don't have the answer right now, but we will. And is there a role to combine therapies? Largely, yes. That is where the field is going. A lot of what we're doing is combining ruxolitinib with other agents and building on the success that ruxolitinib has had, but also things like interferon, building on the success that interferon has and trying to take it to the next level.